Hi everyone, and thank you for joining us today for Tobacco Cessation Resources for Cancer Patients and Survivors, Current Landscape and Call to Action. My name is Mandy Pratt-Chapman, and I'm the Director for the GW Cancer Institute. Before we get started, I want to take a few minutes to go over a few housekeeping remarks. So we ask that everyone keep their phones on mute to avoid any background noise and disruption during the program. So I'm going to repeat that one more time because it always happens. So if you need to step away from your phone, please don't put us on hold. You can keep your phone on mute, but don't put us on hold so that we don't hear your background noise. And also, unless you're saying something, keep your phone on mute. Also, today's program is being recorded, and you will see a few pods at the right of your screen, including a files pod where you can download some files, including the NCCN guidelines, and then some web links that are some good resources for you. You can also chat with us or one another using the chat pod at the top. And if you think of any questions during the presentation that you would like Dr. Ostroff to answer, feel free to submit them in the Q&A pod throughout the event. We will wait until the Q&A portion of the event at the end to go over your questions. There is also, as I mentioned, a web links pod at the bottom containing relevant links and resources, and a PDF of the slides from today's presentation is available for download as well under the files. This webinar is the second in the Comprehensive Cancer Control National Partnership's three-part series on tobacco cessation for cancer survivors, which is a priority area for the National Partnership. The first webinar was hosted by the National Cancer Institute in June, which focused on the research angle. During today's webinar, Dr. Ostroff will focus primarily on tobacco cessation for survivors from a practice perspective. And then in August, C-Change will host the last webinar of the series, which will center around Comprehensive Cancer Control Coalition successes in this area. So feel free to live tweet us throughout the webinar at GW Cancer Institute using hashtags CCCNPChat and CompCancer. So now I'm very pleased to introduce you to our speaker today, Dr. Jamie Ostroff from Memorial Sloan Kettering Cancer Center. Dr. Ostroff is a clinical health psychologist with expertise in helping patients and their families cope with the challenges of cancer diagnosis, treatment, and survivorship. She has a strong interest in working with patients who've been diagnosed with tobacco-related cancers and serves as psychological liaison to the thoracic service and to head and neck disease management. Dr. Ostroff is the Behavioral Sciences Service Chief and Director of Memorial Sloan Kettering's Tobacco Treatment Program. She works with a team of colleagues dedicated to promoting smoking cessation among cancer patients, their families, and individuals at risk for cancer and other chronic medical conditions. Dr. Ostroff, thank you so much for joining us today. I'll hand it over to you.
Thank you, Mandy. I wanted to thank you for this invitation and for all of you that have decided to join us today. Many of us have been at this in this area for a long time, and I remember speaking to small rooms of 5 or 10 people, so there are more than 140 of you on the call, and I'm delighted to see that interest. So today I've prepared some slides that I hope will provide some talking points and action steps for you to take back to your groups. I have an ambitious set of learning objectives, so 6 points that I hope to cover. So I think I'll just get right on with it and hopefully leave some time if I speak in enough of a New York voice for us to have some Q&A at the end. So first I want to do is cover just a brief rationale for treating tobacco dependence in cancer care. Those of you that were on the call last time, this will be a review, but I think it's important to note that we are talking about this because although since we have long known that tobacco is the single largest preventable cause of cancer, what is more recent in our collective awareness is that persistent smoking has associated with adverse outcomes for cancer patients and survivors. I've listed several of these there. There's some wonderful papers that have been published, but I would really call your attention to the most recent version of the Surgeon General report from last year, which really clearly concretized that we should be considering in this age of personalized care, precision care, that smoking represents a modifiable risk factor for cancer patients and survivor, and therefore requires our close attention. So despite those risks of continued smoking, the prevalence of smoking among adult survivors is troubling. What I've shown here is some really nice work that was done by the CDC using the BRFS data, showing population estimates of 27% prevalence rate among adult survivors with tobacco-related cancers. And clearly not insignificant levels with non-tobacco, commensurate with those of individuals without cancer. So this really shows us that among these patient populations, that despite the risks, the prevalence is not trivial. Colleagues of mine in Kentucky, we have just recently completed a systematic review where we looked closely at patients with lung and head and neck cancer. And here again, we found comparable data showing that if we aggregate a large number of papers across study designs and diverse samples, the overall mean prevalence rate of current tobacco use was 33%. And if you look at the group of patients who were current tobacco users at diagnosis, the prevalence rate of tobacco use was 54% for that group after their treatment. Again, demonstrating that this is a risk factor and that tobacco use, or smoking specifically, is prevalent. So moving on now to my second learning objective, I'm going to talk about the best practices for promoting tobacco cessation. Now, as I said earlier, it's incredibly gratifying to see so many of you on the call, and also so many of these national oncologic associations that have made strong policy statements about calling for tobacco use assessment and treatment in cancer care. And it is incredibly gratifying for those of us that have been in the field to see that this topic has certainly come of age and really enjoys the endorsement of all of the leading oncology and quality of care organizations that are responsible for delivering optimal care. I think that I have this slide from ASCO just to give you an example. This is really an excerpt from the ASCO Journal of Oncology Practice, really describing the ASCO perspective, that again, that this should be an integral part of quality care, smoking status should be a core clinical and research data element, and that treatment should be recommended as a standard of quality care. And that pretty much echoes what all of the other organizations have said. Similarly, this was a paper that was published by the National Cancer Institute that got together several representatives from comprehensive cancer centers, and the same, again, echoed the same statement about the importance of integrating assessment of treatment, and this one of the need for more research. So now moving on to my third point, I've already said that it's clinically important, that the prevalence of smoking is high, that all the leading organizations endorse promotion of tobacco cessation. So let's now turn to how we're doing. So first, some good news. This was a survey that was done by colleagues led by Graham Warren, and this survey was done of, I apologize for you about the alphabet abbreviations here, but this is essentially the International Association for Lung Cancer, ISLAC, and ASCO, the American Society of Clinical Oncology. And I really show them both because you can see here that there is strong endorsement about the importance of tobacco affecting clinical outcomes, and that advising cessation should be standard of care. And so I'll follow this format. This is a survey, very large provider surveys that were done, had decent response rate, and the percentage that I'm showing you are the percent that either agree or strongly agree. So I'll take that to mean strong endorsement. So the picture gets murkier when we look at, that was just importance or priority. When we turn to look at actual practice patterns, what you see here is a real divide that essentially asking and assessing readiness, asking about tobacco use, assessing readiness, and advising to quit are nice, robust numbers, all showing nearly above 80%, indicating routine care. Where things crumble is when we look down at the percent that are almost or most of the time discussing medications or actively treating. And those of you that have seen these kind of provider surveys will recognize that this essentially mirrors most provider surveys that are done in primary care and specialty, and really reminds us that that the assistance or the treatment of tobacco dependence is still lagging. So you may say, well, those were community oncologists. Let's now look at our U.S. NCI-designated comprehensive cancer centers. I wonder how they're doing. And, you know, the good news is that there is certainly robust activity, but when this survey was done, less than 50% of the comprehensive treatment centers were actually had a champion for tobacco use, has a tobacco use provider, and so forth. So again, this data is a couple years old, but certainly indicates that there is room for improvement. I'll skip these slides quickly because I want to save some time for question, but I've included them so you can really see this really nice report. This figure showing samples of respondents endorsing communication strategies, and the next one identifying barriers or facilitators, if you will, of, in this case, facilitators of treatment of tobacco dependence at cancer centers. And again, I think there's some really interesting hypotheses to draw from this and really useful blueprinting for considering improvements in quality of care. Another concerning metric, if you will, for the gaps in how we're doing is this snapshot that was done by Peters and colleagues that showed that only a third of the cooperative cancer group trials assess tobacco use. And this is particularly important as we begin to amass a literature showing the biologic effects of continued tobacco use on important cancer outcomes. So there are certainly barriers that exist, and I'm hoping that this will be much of what we talk about in the Q&A, but I've listed here what I see are some of the more common patient, systems, and provider barriers, all of which I believe are imminently addressable with training and practice facilitation and the kind of leadership that Comprehensive Cancer and Control and the other organizations that have set up this webinar today are responding to. So the bottom line for this gap section is that tobacco use assessment and treatment is not yet standard of care. Less than a third of NCI-funded clinical trials are assessing smoking status. Only 60% of those comprehensive cancer centers are offering some form of tobacco treatment, and less than 50% of rank-and-file oncology providers, oncologists, are routinely providing tobacco treatment assistance. And again, certainly what is apparent is that patient, provider, and system barriers exist. So for my next section, I'm going to talk about essentially models of care. There is no one model of care that research has showed us is optimized. So what I'm instead going to do today is provide a bit of an overview about some ways of thinking about models of care, again, with the hope that in the Q&A we'll have time for discussing your own models of care and make the case that more research is truly, more dissemination implementation research is clearly needed in this area. So for those of you that are not tobacco control experts, I just want to introduce that thankfully in treating tobacco use and dependence, we are fortunate to have a long and deep empirical literature that describes that is the foundation for our clinical practice guidelines, and that is summarized here. And so this is important because, generally speaking, all of the recommendations that we have for integrating tobacco cessation services should be consistent with PHS guidelines, which again are generalizable to a broad range of populations. Again, just by review for those of you that are newer to the smoking cessation or tobacco treatment area, this is a figure that summarizes the current FDA-approved medications that assist individuals both with managing acute nicotine withdrawal and promoting superior cessation outcomes. And again, you'll be able to have this as a reference. This is obviously the reference that we give to our providers here at the hospital, and so it's a useful patient tool, provider tool. And I've summarized also here the reminder that these medications work and that they, in aggregate, double the likelihood of the odds ratios of quit rates when used as compared to placebo. The other thing I want to mention is that several of these cessation medication combinations have superior outcomes than monotherapy, and those should also be considered. So that's the sort of general reminder that everything I'm going to say from now on is based on and linked to a very robust body of literature about evidence-based tobacco treatment. And earlier this year, a watershed event occurred when the National Comprehensive Cancer Network, which is the network of these large comprehensive cancer centers, convened a panel of experts in order to develop smoking cessation guidelines for the oncology practice. This is the first time that the NCCN has issued smoking cessation guidelines, and again, it is directly attributable to the kind of leadership and growing evidence base that supports these guidelines. I've included this as handout for you because I think that they are, they're incredibly dense and there's a lot of information. So I'll just go through the next 4 slides and show you that the guidelines first begin, as many of these guidelines do, with a description of evaluation and assessment of patient smoking, with some sample language for screening. Then describes additional assessment that is important, that may be important in determining the tailoring of tobacco treatment to patients and their, in this case, readiness to quit. The next pathway in the guideline reviews strategies for managing former and recent quitters. Again, this is important, knowing that tobacco is a chronic relapsing condition, and that in addition to considering tobacco treatment for current smokers, we also need to be mindful about former smokers and particularly recent quitters. And lastly, some additional comments here about medications and behavioral counseling. And again, I really would, I've included these for you, and I think they're really, really useful for us in thinking about fleshing out different models of care that are consistent with consensus guidelines. I will say as a caveat that these are, because in many cases we do not have randomized clinical trials that show the comparative effectiveness or efficacy of different treatment components. These are consensus guidelines, and in the future, one of the research priorities is to improve the evidence in this area as well. So now I'm going to move on and just this is sort of what I would call my back of the envelope view of the world of coming up with models of tobacco treatment. And so I'm going to describe three separate models. They are not by any means exclusive, and they are not by any means exhaustive, but I think that they'll give you an idea for what I'm seeing out there in the trenches in terms of different ways of treating tobacco dependence. All of these three models begin with some assessment or asking about current tobacco use, acknowledge the importance of oncologists and oncology care providers in advising current smokers to quit, and some acknowledgement that the oncology care team will use their clinical judgment and knowledge of their local resources in order to select a tobacco treatment delivery model that is a good fit for their patients. The first model that I'll describe is, sort of the do-it-yourself, this model. And this is the model where oncologists and the oncology care team opt to take on the delivery of the cessation counseling and the prescribed cessation medication. So clearly there's nothing wrong with this model. We have clinical practice guidelines for this. There's only one concern, and that is, again, colleagues of mine have done a survey that asks oncologists what they prefer, and as you can see, although there's nothing wrong with this model, only 1% of oncologists endorse that this is the type of treatment delivery model that they would prefer. So some obvious concerns about reach with the first do-it-yourself model. So the second model is one that I am partial to, and it's an integrated tobacco treatment program, and I'll describe that to you next. So in this model, again, all patients are asked about their tobacco use, usually in some form like this. This is our Sloan Kettering tobacco screener, and all patients are asked, all new patients are asked this, as well as it's re-administered at transitions of care. It is meaningful use compliant, and all patients that endorse everyday or someday smoking in the past 30 days have an automated referral to our tobacco treatment program. The second part of the integrated care model is to acknowledge that the oncologist and his or her oncology care team have a tremendously important role in advising the patient to quit, providing specific education about the risks of persistent smoking, and equally, if not more importantly, the benefits of quitting, and also to acknowledge the safety and efficacy of cessation medications, as well as the benefits of seeking behavioral counseling. So I guess what I'm saying really here is that the oncology care team is a tremendously powerful voice in recommending and referring patients to quit, and that their role in giving a personalized, specific, empathic advice statement cannot be understated. Again, in this integrated care model, the oncologists and the team are not doing as much of the heavy lifting of the prescribing and the counseling. Instead, they are referring to an embedded tobacco treatment specialist or program for cessation counseling, and that person is then conducting an intake and using medications, cessation medications, both to reduce acute nicotine withdrawal, which may happen for individuals that are undergoing lengthy medical procedures, but also using cessation medications to increase the likelihood of cessation. I've just shown this to you. Those of you that have really, really good eyes can see that this is a flow diagram, an algorithm of a way that we might adopt the clinical practice guidelines to consider special contraindications or risk factors of cancer patients. In this case, essentially, how do we choose cessation pharmacotherapies, or a decision tree? In this case, this algorithm takes into account cancer-specific and cancer treatment-specific issues, such as the nature, the location of the tumor, and the side effects from the cancer treatment in order to determine whether or not the cessation medication is either in red, contraindicated, yellow, maybe contraindicated, or green, in this case, no contraindications. And we've developed a lot of these decision trees to best sort of to tailor and modify, if you will, the clinical practice guidelines for the special needs of cancer patients. So lastly, the model that I want to speak of is, again, a very common model, in this case, particularly among settings that are community-based or that haven't yet acquired resources to have an integrated tobacco treatment program. This is essentially the same asking, advising, asking about tobacco use, advising smokers to quit, but in this case, referral to community-based cessation support services, such as those that I've listed here. Increasingly we are seeing community-based cessation resources that are acknowledging that there are, at this point, 14 million cancer survivors, and if you go back to the prevalence of persistent tobacco use, you really begin to see that this is a sizable cohort of smokers who will likely benefit from some targeted cessation resources and materials. And again, some of these organizations will be well known to many of you, and they have adopted specific cancer patient education materials for both staff and, in this case, patients and survivors. So I also thought I would highlight some examples of some of the, what I would call our early adopters of tobacco treatment at the Cancer Center. And, you can come back and read these details. What you'll notice is that the ones that exist at cancer centers tend to be a higher degree of treatment intensity, which means that they have more than 4 contacts of over 15 minutes, and that they, again, I would call these what's often called, higher intensive or level 4 treatment intensities, and you'll see they vary in terms of individual counseling, group counseling, but much of this is being delivered by an on-site tobacco treatment specialist. You'll also note that they vary in their funding sources, and this is now dated, but certainly when this slide was made, we certainly had woefully inadequate reimbursement for tobacco treatment, and we all hope that this will be changing under the Affordable Care Act. So here's an example, again, of a model that was developed at Roswell Park. Again, really, I like to draw these kind of flow diagrams to be able to look at the clinical workflow. Here is one that was developed by Roswell Park. It's very similar to the one that we use here at Memorial. I'll make just a couple of comments about our program, and then I'm glad to share some more information during the Q&A, is that our program, like many, recognizes that there will always be more smokers than there are staff trained and available to treat them. And so our practical evidence-based compromise is this hybrid stepped care model where all smokers are, all patients are identified as current smokers. They receive personal advice and tailored self-help materials by the primary oncologic team. A proportion of those are referred to our team of tobacco treatment specialists who are oncology nurses who have gone on for certification as a tobacco treatment specialist. And again, I'm glad to talk more about that in the QA. And then lastly, we've got this maximum intensity, which is recognizing that a subset of cancer patients will have comorbid conditions around psychiatric and substance abuse, and these individuals generally need more intensive tobacco treatment in concert with their overall psychosocial support care services. I've boiled down in this next slide some recommended ingredients for tobacco treatment programs, and again, I think I've covered most of these. And just to give you an idea, about it certainly relies heavily upon staff and patient education about the benefits of cessation and the risks of continued smoking. A standardized screening method to identify all smokers at intake and throughout the continuum of care is essential. Many of the programs are moving towards a embedded clinical staff with expertise. It's not necessary, but I believe that is a trend that we are going to see more of. Also an acknowledgement that patients will vary in their motivation to quit, their readiness to quit, and that programs to help cancer patients are going to need to be responsive to those individual smoker backgrounds, and to be able to build and maintain quitting motivation and strength skills in coping with smoking urges. It's important to liaise with the oncology care team about the cessation medication. Fortunately, these medications are well tolerated, but they certainly need to be conveyed as part of medication reconciliation for all patients who are undergoing active treatment. I'd also say that I think some of the finest programs that exist also have companion research programs that both complement and benefit from the clinical service. And lastly, a point that I'll make in my last segment of this talk is that the importance of collecting and monitoring cessation outcomes and other quality of care performance data in order to embark upon continuous quality improvement. So the next point that I want to make is to specifically review some existing resources for tobacco cessation among cancer survivors and their and patients. I want to call your attention to these toolkits that were established by the American Society of Clinical Oncology. One is for the oncology provider, and one is a list of resources and guidance for patients and their family. They are useful, they are widely available, and they also include additional community resources. And then related to that is just to give you an idea, and I think that these are included, I'm really wanting to promote the resource. It's a curated list of resources that is both at the end of the ASCO cessation toolkits as well as the NCCN guidelines. These are resources that have been tied towards resources that are population-based, that are, whenever possible, tailored to the needs of cancer patients, and also provide some additional citations and bibliography for those of you that are in the process of making the business case. You'll also find some useful, not just treatment resources, but clinical rationale and arguments about return on investment. Lastly, I want to close and leave some time to talk about the importance of addressing barriers and promoting strategies to increase implementation. So certainly, more research is needed to identify both patient, provider, and system-level barriers that I highlighted earlier in the talk. I think one of the things that we have a clear understanding of at this point is that we need to create additional opportunities such as this and the entire series that is being sponsored to provide cancer-specific tobacco treatment training and practice facilitation, and that we also know that that those sites that have made tobacco use assessment and treatment a quality of care standard are establishing, monitoring, and providing performance feedback in order to continuously improve their tobacco outcomes. I've listed here, again, some examples of specific barriers and strategies that one might consider. One of the things that I haven't yet mentioned is that there is one of the biggest barriers that oncologists cite in treating tobacco dependence are perceptions that patients are resistant to quitting, and the data, first of all, the patient data certainly doesn't support that those strong negative beliefs, and that the strategy for addressing those provider barriers are things such as emphasizing motivational interviewing counseling in our educational programs, dispelling myths and misconceptions about tobacco treatment, and providing a strong foundation for understanding nicotine addiction. And I suppose what I would add to this is the development of counseling strategies that are empathic and non-judgmental, and that recognize that for these patients, their persistent tobacco dependence is very heavily driven by nicotine addiction, and they need and they benefit from education and, again, an empathic interactions with healthcare providers. Again, I think that this barrier that comes up a lot is about lack of time or competing priorities, and I think that I've tried to illustrate today that there are several ways to extend the oncologist or an oncology nurse time, both in terms of embedding a designated tobacco treatment specialist, referral to Quitline, and other community-based resources. And I suppose the other barrier that I would be remiss if I didn't mention is that it's certainly been identified that about the importance of addressing smoking among healthcare professionals. And so we and other programs like us also offer free evidence-based tobacco treatment to our employees with the understanding is that we need to be promoting a smoke-free staff in order to promote smoke-free patients and their families. This list is a little bit longer because I think from where I sit, we still have many institutional and system barriers in actually integrating our clinical practice guidelines into real-world clinical settings. And I've listed a couple of the things that I and others have found to be helpful. I suppose what I want to highlight are the points about identifying your clinical and administrative champions, establishing tobacco treatment as a quality care metric. I think that all of the really wonderful work that's been done by the partnership and the CDC to promote tobacco-free hospital policies has tremendous relevance here, that there are existing quality cancer care metrics that can be used in order for you to improve upon and integrate services. There's a real recognition that that it's important to have a standardized method for tobacco use screening, and that I and others have been part of an NCI task force, an AACR task force that has come up with very specific recommendations for assessing tobacco use, and we've embarked upon the very laborious effort to do cognitive interviewing to make sure that they are relevant specifically for cancer patients and survivors. I believe that those are currently available on the GEM website and other sources. It's also important to assess exposure to other tobacco products. We certainly learned here that it was essential to be asking patients about electronic nicotine delivery systems such as the e-cigarettes, and also be asking about secondhand smoking exposure if we were going to be devising a comprehensive tailored treatment plan for patients. I've mentioned here, I think that one of the ways that we increase patient utilization and program reach is to emphasize addressing the stigma that patients feel and in reluctance of disclosing their tobacco use to oncology care providers, which prompts the importance of providing empathic counseling and quitting support. Another barrier, again, a practical one that I think that hopefully will come off the list in the not-too-distant future, is issues about the lack of reimbursement, but certainly it's important to build a billing system that supports insurance coverage, and that means including appropriate ICD and CPT codes. And I think I've covered all the rest. So in closing, the take-home messages that I want to leave with you are, first, that despite the risks of persistent smoking, a substantial proportion of cancer patients and survivors are current smokers. That oncology providers view tobacco cessation treatment as a priority for their patients who smoke. However, in most settings, tobacco dependence treatment has not yet become integrated as a standard of cancer care. We are increasingly identifying patient, provider, and systems-level barriers that lend themselves to academic, community, health department partnerships that involve staff training, practice facilitation, all intended to improve quality of care. And all of this is important as we all work together for the end. And so that concludes my comments for today, and I welcome the opportunity to hear more about your programs and answer any questions.
Thank you so much, Dr. Ostroff, for sharing your expertise with us. We're going to begin our Q&A portion of today's program in just a moment. So if anyone has questions for Dr. Ostroff, please submit them in the Q&A pod or the chat box now. And while I give you some time to get your questions in, I want to review some of the links included in the link pod with you. As I mentioned earlier, this webinar is the second in the Comprehensive Cancer Control National Partnership's three-part series on tobacco cessation for cancer survivors, which is one of the National Partnership's priority focus areas. And you can read more about the National Partnership's focus areas on their website. And in case you missed the first webinar sponsored by NCI in June, the URL for the archived recording is included in the web links. C-Change will also be hosting the third webinar in the series on August 20th at 3 p.m. Eastern, so save that date and keep an eye out for more details for that. And there are also some links to Memorial Sloan Kettering's tobacco treatment program in case you would like to learn more about Dr. Ostroff's program, as well as ASCO's tobacco cessation and control resources and NCI's physician data query entry on smoking and cancer care, which summarizes existing evidence. The national network consists of 8 national CDC-funded networks for tobacco and cancer prevention that are actively engaged in work around tobacco and survivorship, with a focus on reducing disparities within specific population groups. And the networks have a variety of resources available to coalitions that can be accessed on their page. And finally, there's a link to our evaluation survey for this event to offer you a chance to provide feedback and help us improve our future offerings. So Dr. Ostroff, I'm going to start with a question about dealing with clinician resistance. So I know that you mentioned that some providers don't see it as a patient priority, but in my experience, I've also talked with clinicians that simply feel like patients are going through enough with cancer treatment, and it's just, timing-wise, it's a tough ask to try to get people to quit smoking while they're starting chemo. So I just wondered what your what your response to that would be, and how to deal with clinician resistance when it's more about feeling like they're burdening a patient with too much all at once.
Yeah, that's a really good question, and we certainly hear that as a counter for intervening at the time of diagnosis. Generally my response is that in the beginning of treatment, when a patient comes to us, they're looking for guidance. They're looking for us to share with them evidence-based practices to improve their survival, reduce their treatment complications, and essentially to have a good outcome. And I would say that that's how I frame tobacco cessation. And I acknowledge truly that this is both the best and the worst of times to quit, but that fortunately there's something that they can do to make a difference in their cancer care outcome, and that I and the rest of their team are here to support them in making that change. So I think it's how you frame it and how you think about it. I think it's very consistent with exactly what patients expect for us in the beginning of a diagnostic workup, but I recognize that for many patients there's going to need to be a validation that this is difficult and a referral to other psychosocial support services for patients and their families.
Okay. And, one question that came in also was related to, there's kind of this disconnect between comprehensive cancer control and a busy clinical practice. And while clinicians are busy with day-to-day patients, cancer control programs are taking a longer view and have strategic goals and objectives that they're trying to meet at a population level. How would you suggest that comprehensive cancer control programs connect with community-based partners and connect with clinicians in a meaningful way, given that their day-to-day priorities are a little bit different and kind of impacting that clinical behavior can be difficult?
I think that's a great question. I think one of the things that cancer control programs can do and do really well is serve as a liaison between the clinical providers in the community and the research community. And so I think that getting the word out about seminal papers, suggesting speakers, sharing resources are several of the ways that cancer control programs can assist. I also think that, essentially we measure what's important. And so if we measure cessation outcomes following cancer diagnosis, we will be acknowledging their importance as a modifiable risk factor and driver of cancer outcomes. So I would say resources, liaison, and measurement at the at the population level.
Okay. And I just want to point out, Delphine asked about tobacco treatment specialist training, and Eric sent a link. I just wanted to call attention to the chat box in case anybody else had that question. For tobacco treatment specialist training, it looks like Mayo Clinic has a program. Are there any other training programs or certification programs that you would recommend, Dr. Ostrov,
yes.
if someone would?
Yes. So there is an organization called ATTUDE, and this is the National Organization for Tobacco Treatment and Dependence, and it's ATTUD. And if you go to their website, you'll see that Mayo is one of the certified programs. I believe there are 13 across the country, and that's also a really great resource for people that want additional training.
Thank you. That's great.
They also have a, I'm sorry, I was supposed to say they also have a list of competencies, which may also be useful for people that want to do self-studies.
Great. Thank you. That's great. And can you just shoot that link to the chat box? So Monique's going to put that link in the chat box so everyone can see that in case you're interested in following up on that. And then we also had a question about the payment for services. Eric asked if there was going to be, how reimbursement would be structured, if it would cover the cost of staff time. And more broadly, I was kind of wondering, how I noticed in your chart that most of the programs in terms of early adopters had operational funds that paid for these kinds of services in the hospital setting. And as you can imagine, you did mention that there was some links to an ROI argument. Can you give us any pointers or a distilled summary of what some of those cost arguments might be and where you see reimbursement going for this?
Yeah, well, first let me say I usually ring up my colleagues in cancer control for these kinds of reimbursement questions. This is clearly a moving target and one that we are very much in a sea change for. My understanding, though, is that both counseling and cessation medications are reimbursable for licensed independent practitioners, and obviously physicians, NPs, physician assistants, and so forth, depending upon the state. Many of the cancer centers and community settings that I know are developing pilot programs to look at recovery of reimbursement in preparation for estimating how much of these clinical care resources may be recoverable. I think that, so I apologize, I feel like I'm not the expert in that, but I'm glad to provide some links. I think much of this is state by state, and that thankfully it's going in the right direction, but not as quickly as many of us would like. I think in terms of practically speaking, I think that most of the programs, there are certainly programs that are generating clinical revenue in a meaningful way to support their staff, and I think that those are really to be applauded. I also think that majority of the programs are using a combination of pie slices that include operating expenses, clinical revenue, philanthropy, and research funding.
Okay. All right, great. And I'm just looking if there's any additional questions. I guess seeing no other questions right now, my other angle on this would be, what do you think the potential is for some of these services being wrapped into bundled payments or something that's more of a quality indicator for oncology care, given the direction of payment in terms of value-based purchasing and more quality kinds of, payment for quality rather than fee-for-service? Do you think that this is something that could be advocated for in terms of how oncology care should be delivered and compensation should reflect that?
Yeah, I mean, I certainly would endorse that, and that's the business model that we've adopted here, is that I make the argument about using our hospital operating expenses because it is just, frankly, good quality care. I think that I would love to see advocacy that many of these quality care indicators move from what they are now, which is obviously voluntary programs such as ASCO's COPI program, to those that have incentives and or penalties. But again, I think that would be a really important clinical cancer control program partnership to move towards advocating for those kinds of inclusions in bundled payments and bundled services.
Great.
So I'm glad you brought that up. I think it's a great idea.
Yeah, that's kind of where my mind is on a lot of this stuff. So hopefully we'll be moving in that direction. I don't see any other, oh wait, hold on. Is treating tobacco use and dependency available? I'm not sure what that question means. Is treating tobacco use and dependency available? If the person who posed that question could clarify that would be helpful. There was another question that somebody asked about calling numbers for tobacco cessation, and I know there's 1-800-QUIT-NOW. Are there other numbers that you would suggest people refer patients to in terms of quit line support? Yeah, I've listed those in the on one of my slides. That small slide that nobody could read was prepared so that you could in fact have at your fingertip the kinds of phone numbers, and that includes the American Cancer Society, the National Cancer Institute, some of the state quit lines, particularly I think you had the Michigan folks on last month. They have specialized services. But as I said, I tried to include as much of the cancer-specific resource information
on both the NCCN and that slide that includes the resources.
Great. So for anyone who was looking for that specific information, if you want to download the slides and take a look at that, that would be your best bet. And I'm just waiting to see if there's clarification on this question about treating tobacco use and dependency. It says the clinical practice guideline named treating tobacco use and dependency. I'm not sure what the question is asking, so I'm not sure how to pose it to you. I apologize. But are there any? We're gonna wrap up, and possibly for the person who wanted to know about the clinical practice guideline question, we will be transferring this. Are we transferring this? No. Okay. If you have a question and you want more clarification, you can send it to our CASNAP email account or cancercontrol@gwu.edu, and we can shoot that over to Dr. Ostroff, and she may be able to answer that for us and send that back to you. So since we are a few minutes before the hour, I'm going to direct you to our evaluation survey, and if you could make sure that you fill that out so that we can continue to do a better job each time we provide a program, we would appreciate it. And we thank you so much for all of you joining us today on this important topic. And Dr. Ostroff, we really thank you for being so generous with your time and for your knowledge and passion for this topic. So we're going to open up our evaluation survey. It should open in your browser as soon as the event concludes, and we hope to see you at another webinar or event soon. Thank you.